Hello, everyone. Dear friends and colleagues, as IDF MENA Regional Chair, it's really deep pleasure and honor for me to introduce the 14th IDF MENA Blue Circle webinar launched since June 2020. The topic of this webinar today is about diabetes and CKD. This session, with focus on chronic kidney disease, will be animated by eminent experts from MENA region, Dr. Nizar Atallah, Ala Bashir, Rashid Malak, and Muhammad Hassanin as speakers, and Hazim Abdul Razak as moderator. It promises to be very attractive and informative by the quality of the teams chosen and by the credibility of the speakers. I take this opportunity to recall, as I did during the Regional Council meeting on the IDF MENA region on January 8, 2022, that we are very satisfied with this activity, which has very high attendees from the MENA region and outside. We wish at the same time, and with the stronger involvement of all the association of the IDF MENA region, to strengthen this activity in the future. A great thank to the scientific committee of the webinars for the beautiful work that it continues to realize. At the same time, I would like to thank all the other working groups in the MENA region for the wonderful work they are doing, as well as all the association in the MENA region for their exceptional dynamism. Many thanks again for all participants from MENA and outside. My deep thanks also to Amber Event and to Bayer Company, the sponsor of this webinar. Thank you for your attention.
Good evening, everybody. Thank you very much, Professor Jamal, for this introduction. Dear colleagues, it's a great honor for me to moderate this important session about CKD in type 2 diabetes. And it's a pleasure to have with us a very distinguished speaker who will talk about different aspects of chronic kidney disease in type 2 diabetes. We all know that the management of type 2 diabetes, it should be conducted by a multidisciplinary team, including endocrinologists, cardiologists, nephrologists, among many others. And also it is well known that almost 1/4 to 1/3 of all type 2 diabetics, they are having some degree of chronic kidney disease. And a significant number of those who have chronic kidney disease, they don't know that they are having a renal impairment. This fact showed the importance of multidisciplinary team management as well. Many studies had shown the importance of multidisciplinary team management in achieving good outcome in terms of reduction of chronic kidney disease progression and reduction of the associated cardiovascular events. So today we will hear from our distinguished speakers the different aspects of chronic kidney disease in type 2 diabetes. First speaker would be Dr. Muhammad Hassanin. He is professor of medicine, Gulf Medical University, Cardiff University School of Medicine, and chair of the Diabetes and Ramadan International Alliance. The title of Professor Muhammad Hassanin talk would be under the heading, The Burden and Characteristic of Chronic Kidney Disease Patients. Professor Muhammad, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Professor Hazim, for the very kind introduction, and thanks for Professor Jamal for the regional introduction and for the support and the initiatives done across the MENA region. Of course, the diabetes and the kidney problem is a very, very important problem. I personally have a very special interest in the issue. When I was working in UK in a big hospital. Our department was a joint department between us and the nephrologist, including the dialysis unit and the outpatient facilities was shared. And we had two joint clinics with the nephrologist. Myself as an individual, my mother, rahmatullah alayha, she had diabetes and she had CKD and she had dialysis. And indeed, rahmatullah alayha, she died in the dialysis unit. So I have personal as well as professional link with diabetes and the kidney issues. And we want to understand the burden of diabetic nephropathy. Now, when we say that 30 to 55% of people with type 1 and diabetes will have nephropathy, that does not mean that if you go into your database, you will find 30 to 35% of people having nephropathy. What it means that a third of people with diabetes at some stage during their lifespan will develop nephropathy. And of course, we all understand diabetic nephropathy is a major cause of morbidity and mortality, regardless of the type of diabetes. And also, we know from lots of data, the strong link between cardiovascular disease and diabetic nephropathy. People with diabetic nephropathy do not die because of uremia, they die because of cardiovascular problems. And that is the fact of the matter, whether they are with end-stage renal disease or pre-end-stage renal disease. And nowadays, especially in our communities with very high prevalence of diabetes, the diabetes is the main cause of end-stage renal disease. And I'm delighted that in the program tonight, we have an eminent nephrologist colleague with us to get the input of the nephrologist as well. So data from many years back was showing that the other causes for nephropathy, this is from 2014 USA data, that the other causes for nephropathy, for end-stage renal disease, such as glomerulonephritis or cystic kidney, are not increasing as much as the problems of hypertension and diabetes, and both are, of course, very much interlinked. So this is a problem that we are bound to see more and more in our diabetes patients and our communities. And if you were to look into any database of patients with end-stage renal disease and diabetes, of course, because of sheer numbers of type 2, the majority of them will be with type 2 diabetes. So that comes because of numbers. Now, it's quite interesting that death because of cardiovascular problems, acute myocardial infarction, stroke, amputation have dropped from the very high rates in the 90s to a much lower rates 10 years ago. And I presume that this lowering effect is lower and lower with the advent of the new therapies. But perhaps it's a good point that for patients of end-stage renal disease, it not increase, but we would like to see it decreasing as well. And I'd love to see data from our region regarding this as well. The natural history of diabetic nephropathy starts pretty early, from the early stages of diabetes, specifically in people with type 2 diabetes, where we see the increase in eGFR, the hyperfiltration, and that is matched with an increase in the urinary albumin excretion, and then it stabilizes. And as the eGFR goes down, the urinary albumin excretion goes up until it becomes a very significant high level, and at the same time, the glomerular filtration rate has dropped. So that sort of opposite scissor shape is very important for all of us to understand, where the different stages, from the silent stages of the hyperfiltration and the silent diabetic nephropathy to the clear incipient and then the overt diabetic nephropathy, and finally, unfortunately, the end-stage renal disease. This sort of pattern is very much related to time. So a person with early diabetes who has significant nephropathy we need to think of potentially other causes of nephropathy rather than diabetes itself. Of course, we can have here microalbuminuria, but to get serious impairment of glomerular filtration rate and proteinuria early in diabetes might need for us to think harder and to consider what is the exact cause of this and referral to the nephrologist earlier. Now, there is an overlap between the protein excretion and the eGFR, and some people have one or the other. The vast majority have an overlap. So you can see here that there is a possibility of having non-albuminuric renal impairment. This is 9%. And as I've just been explaining, if you see the rate of progression is high, not just a marker, but not just that the eGFR is low with normal albumin, it is the rate of progression of the eGFR, how fast it is, because that could be very serious. Now, of course, when you have someone with albuminuria and renal problem, that is the vast majority of the group. No CKD, of course, is still the very high proportion. And when we do have some people with albuminuria, but without any renal impairment, and that's also a sizable proportion. And we wish to not progress with impaired eGFR, because that could be, of course, with lots of impact on the patient's life. So 13% have renal impairment in this particular series from the NHANES third edition. This data was published 20 years ago. And when they looked into the microalbumin excretion of them, some of them were normal, some of them were microalbuminuria, and some of them were macroalbuminuria. So renal impairment does not necessarily have to have proteinuria or microalbuminuria. In some it is yes, and some others it's no. But of course, we know when both problems are there, the advanced study, which looked into over 10,000 persons with type 2 diabetes, and when they were split into the different levels of microalbuminuria and different stages of the eGFR, from below 60 to 60 to 90 to above 90, and from normal albuminuria to macroalbuminuria. Of course, the cardiovascular death would be highest in those who have the highest level of proteinuria and the lowest level of eGFR, and vice versa. The people with normal eGFR and normal microalbumin excretion will have the lowest level of cardiovascular death. When you draw a line from this point to this point, you will clearly see the big difference between the two. And the same would be for renal events, even much better. So in those with normal albumin excretion and normal eGFR, they're very unlikely to get renal events in comparison with those with the opposite, macroalbuminuria and low eGFR. So it becomes quite clear. Now, when you try to understand the prevalence of what we call chronic kidney problems, this is data from a survey that we did across the region, including Asia. The survey was meant for Ramadan, but part of it we were collecting the characteristics of patients, so comorbidities. And this is published a year ago. And as you can see, the survey included a large number of people, as you can see here. This is type 2 diabetes persons. So this is the data for type 2. So the overall of them, if you can see here, the data is split into according to age. But overall, how many have nephropathy? This is neuropathy, sorry. The nephropathy is the line below, the 10%. So out of the total number of patients that have nephropathy was 10% in the group of patients. This were a group of patients with a mean age in their 50s. And it's very much related to age. So if you look into the cohort who are above the age of 65, it was 17.7%. if you look into the cohort who are below the age of 65, it was 7.9, or let's say 8%. So 8 versus 18, that is roughly about 2.5 times higher. So it's very important to understand the prevalence of the problem in our community. Now, when you look into the group of patients with the chronic kidney disease, and they were nearly 600 persons with chronic kidney disease, now the vast majority of them have hypertension, 82%. 67% of them have hyperlipidemia. So the two problems that are serious risk for cardiovascular disease are in abundance in this group. Retinopathy was in for nearly half the number of patients. And of course, we know the strong link between retinopathy and nephropathy. Neuropathy was 38%, and diabetic foot problems were in 7.6% of the patients. Now, when you try to understand the gender and the HbA1c of the group, as I said, 10% of the cohort had CKD. There were more men than women, 55 versus 45%, and the HbA1c was not good at all, was 8.7%. So clearly, understanding our patients with diabetic nephropathy is quite important. Now, here is data from Saudi Arabia that was published 10 years ago in the Saudi Journal of Kidney Disease and Transplant, and they looked into 491 participants. Some of them had CKD and some did not have CKD. Now, I understand that the cohort with CKD are only 28 patients, but it just gives us an idea about some of the problems that we're talking about. Again, the male to female gender is much higher in those with CKD, which is not the case in the general population. The age, the vast majority of the patients with CKD are with the longer duration of diabetes and age, the older age versus where compared to those without is different. And the presence of hypertension and dyslipidemia in this cohort was lower than the other one that we saw, but still much higher than the other cohort of people with that from the global survey. I'd like to remind you that this cohort was not all diabetics, and as I mentioned, that CKD is common in people with diabetes, and as you can see here, 39% of the cohort of CKD patients are people with diabetes anyhow. So we've talked about microalbuminuria, and microalbuminuria, as we know, is a major microvascular risk factor, and it can cause worsening of retinopathy, and it can cause worsening of nephropathy. The link with nephropathy was highly statistically significant, and this really is important for us. For all microvascular complications, the overall, it is high, and that obviously further help us to understand that intensification of treatment is important, with better glycemic control and better blood pressure, as we saw in one of the studies. So when you look into here, another study from the same group looking into 42 persons with albuminuria versus 375 persons without albuminuria, you will still find a very significant difference. For example, previous cardiovascular disease, 11.9%, 12% versus 0.6%. So the correlation of from microalbuminuria or albuminuria in general with cardiovascular events is very high. Now, I would like to see how well are we doing with our patients. And this is data that we just analyzed, and we presented some of it into the Emirates Diabetes and Endocrine Congress that many of you have attended lately. And here is the subgroup of patients with eGFR of below 60. So to start with, this is data of 13,700 persons. So when we find that only 603 have an eGFR of below 60, 10% would be 1,300. So 5% would be 650. So this is below 5% of our population in Dubai Health Authority, from what we see, have eGFR of below 60. The split, again, is more males than females, 45 versus 46, similar to what we say in the global survey. And the very vast majority of them are people of the older generation. If you look into the green, which is from 60 to 69 years, and the dark blue, which is the above 70. So if you were to say above the age of 60 years, it's 80% of the patients. And if you go for above the age of 50 years, that will be 92% of people with abnormal eGFR, or below 60 to be precise, are people who are above the age of 50, and the vast majority of them are even above the age of 70. Now, if you try to understand what stage of eGFR they are, 60% nearly are stage 3A, and another 25% are stage 3B. So we are dealing with perhaps if you were to say that stage 3E is a stage where many things could be slowed down and reversed. Obviously, we need to work on all of them to prevent the problems. Preventing the problem, part of it is glycemic control. And as the vast majority have stage 3A, I would imagine that we really need to get the HbA1c even better than this. I'm delighted that 51% have an HbA1c below 7, and that another quarter have an HbA1c below 8. If we can work on this quarter to get into the below 7 as well, that will be a massive achievement to say that 75% of patients with an eGFR below 60 are with good glycemic control. Blood pressure is something that also needs a lot of improvement. Now, the target blood pressure, and I'm not going to dwell too much into this because Professor Malik will soon do his presentation on hypertension. But if you look into the recommendations, in most recommendations, they would say as low as possible, or certainly below 130 for people with end organ problems such as eGFR below 60. Unfortunately, in our cohort, this is only 30% of our patients have a systolic blood pressure of below 130. And for diastolic blood pressure, the situation is a bit better, of diastolic below 70. And if you go to below 80, then that will be nearly 80%. Below 70 is 40%. So diastolic blood pressure does not seem to be a problem as much as the systolic blood pressure, which certainly is a bit more problematic and difficult to achieve in blood and hypertension. So we obviously need intensive glycemic control, and that needs to be taken with a pinch of salt. So the recommendation is go as good as possible, provided that you will not end up with exaggeration of hypoglycemia in people with nephropathy. So the different studies have looked into this, and Dr. Ala will cover this point. I will not dwell on it. I just say that it's important that we get good glycemic control. So we know from the advanced study that combining good glycemic control as well as hypertension control would be of significant impact. And the mega point of the advanced study was indeed the reduction of renal impairment. But we also know that hypoglycemia is very much related to the renal function. People with higher rates of albuminuria, as well as people with higher rates of creatinine, have more severe hypoglycemia. So it is important that as we aim for tighter glycemic control, we don't end up with causing more harm than good. I'm not at all saying we should be relaxed, but I'm saying we need to be careful and with our choices and our targets. As I mentioned, I'm delighted personally that we have a nephrologist with us tonight. We As I mentioned, I've worked for many years in a joint setting with a nephrologist and Dr. Ala, who will cover a session today from our hospital. He's our diabetologist currently doing this joint activity. I think the bottom line is the most important aspect is to have a discussion with a nephrologist who understands diabetes, passionate about diabetes, and to have an agreement with them on which type of person I will see, which type of person they would see, how can we establish a joint activity perfectly if it's in the same setting or with some sort of collaboration. When should we start referring to them, people, to their nephrology clinic? And here are some of the criteria. I'm not saying that this is the only criteria, but this was the criteria that we established when I was working in UK. So in summary, Mr. Chairman, ladies and gentlemen, diabetic nephropathy is a major cause for morbidity and mortality, regardless of the type of diabetes. Early detection can alter the natural history of diabetic nephropathy. We definitely need to understand the profile of people with diabetes and CKD so that we can achieve better treatment targets. A holistic approach is really necessary so that we can tackle all the possible problems that a person with early versus advanced diabetes and CKD could encounter, so we can avoid the morbidity and mortality they all have. And finally, Ramadan Kareem, Ramadan is coming in a few days' time. Thank you all, and I stop sharing, and I look forward to the questions and answers later in the at the panel discussion.
Thank you very much, Professor Mohammed Hassanein, for this interesting talk about the epidemiology of CKD in diabetic patient and its related problems. Now, we will give the talk to Professor Rashid Malik. He is the professor of internal medicine, Faculty of Medicine, Satif University. He is head of the Department of Internal Medicine, Diabetes in Satif University Hospital, Algeria. And his talk would be under the title, Target Blood Pressure and the Class of Antihypertensive Drugs. Professor Rashid Malik.
Hello, everybody. It's a very double honor for me and a pleasure to present you this topic about target of blood pressure or class antihypertensive. It's a very double problem and very rare debate. I would like, first of all, to thank Dr. Hassanein and Professor Jamal Belkhadir for this invitation for the MENA Blue Circle program. This is my agenda. I would like to present these common consequences of hypertension and diabetes. And the two diseases have cardiovascular complication, and this heart complication is for brain, arteries, heart, and kidney. If you have the two diseases, you have a multiplication of complication and cardiovascular disease. But this is not only the problem. The problem is from insulin resistance and diabetes. And when you look all of these consequences and all these factors for physiopathology, you have here the renal SGLT2, which have a determinant role for this physiopathology, and I will speak of this in the end of my presentation. Most people with hypertension do not have it under control, and aware they have it for 47% aware they have it, and 37% receiving treatment, but only 14% have a blood pressure controlled, and a reduction of 20 millimeter of mercury systolic blood pressure halves vascular mortality at age between 35 and 65. And most patients with hypertension, more than 90%, will be evaluated in a primary care office. The second problem, it's important, it's the comorbidity with diabetes. And look at this comorbidity like NAFL, like obesity, like hypertension, like CVD, like kidney disease. And all of these have consequence in morbid mortality, cardiovascular morbid mortality. And you have to take in consideration all these comorbidities with hypertension and with diabetes. We are multiple steps for strategy of management of hypertension. First, we have to diagnose it, and then evaluation with exam and laboratory evaluation like CKD, like kaliemia, and screening of organ damage and cardiovascular risk and comorbidity, and then evaluation of cardiovascular risk. And then after achieving this, think about targeting the blood pressure or the antihypertensive class. And when you look at all these factors, we have to join the two targets. I begin with the target of blood pressure. The importance of blood pressure reduction is too often forgotten. But since this publication in the Lancet in 2000, you know that reduction of hypertension have this consequence with reduction of myocardial infarction, about 20 to 25%, stroke, 35 to 40%, heart failure, more than 50% with renal failure. So the importance of blood pressure reduction is very, very the first thing we will do when you manage hypertension. The reduction of major cardiovascular event according to reduction in systolic blood pressure in clinical outcomes trial. And the circle represents the volume of data and for trial in this publication in the Lancet in 2016. And we know that the reduction of major cardiovascular risks is with a relation with the reduction of blood pressure. If you look at the risk, at the cardiovascular risk, you know that with hypertension, when we have diabetes, mellitus, when we have cardiovascular disease, we have a high risk. And in the monitoring, the target of blood pressure under 130 for systolic and 80 for diastolic in individuals must be for elderly and based on fragility of this. And since we have the lot of data and all study, you have data for drug versus placebo, data comparing different drug, and data comparing different blood pressure target. And since that we have reduction of the threshold of initiation and titration of antihypertensive medication, and all this study maybe contribute for reduction of the threshold of hypertension. If you look at the recommendation of ADA in 2022, you have in the first target of blood pressure is the first indicator for initiating treatment. In the two cases, we have initial blood pressure if you are more than 114 and 19 for blood systolic, diastolic. You have to start one agent, and when we have more than 116 and 100 for diastolic, we have to start two agents. But when we have with diabetes another factor like albuminuria, after the target of the blood pressure, we have the choice of the class of antihypertensive. You have two indicators for the management for the ADA. And then the choice of the class of antihypertensive depending of the action and for the action of this class, like ACU inhibitors and ARB and CCB in the second intention and diuretic at the last intention. If you look for the target of blood pressure and for class of antihypertensive, you have another point we discuss with the ADA. It's the axis of blood pressure control and adverse effect. When we have adverse effect, we have to choose the class of antihypertensive. And the tolerability and side effects is another indicator for choice of class of antihypertensive treatment. In the algorithm of treatment of ECH 2020, you have first triple the threshold of or the target of blood pressure, and we have two points, essential target and optimal target, which taking into consideration the reduction of blood pressure at least 20 or 10 millimeter of mercury, ideally to under 114 for systolic and 19 for diastolic. And for optimal treatment, we have in people under 65 years, blood pressure under 130 and 80 for diastolic. But if we have elderly people, we have to target the blood pressure with the threshold under 114 and 19 for diastolic. Another point, it's important when you look at the resistant hypertension, you have a definition, and when we see the definition of resistant hypertension, we have patient prescribed more than 300 antihypertensive, including a diuretic class. The choice of the class, it's important to consider if you have resistance of hypertension. What is the ideal blood pressure target? In the trial sprint, intensive blood pressure reduction was associated with significant reduction in composite cardiovascular risk. And the first goal of antihypertensive therapy should be to lower blood pressure below 140/19. Once this goal is achieved, a blood pressure of less than 130/80 for diastolic can be targeted, keeping in mind to avoid signs of organic hypoperfusion, such as orthostatic hypotension and elevated serum creatinine. We have also target of blood pressure, in particular patient, maybe elderly, CKD, diabetes, and patient with CVD. And when we look, for example, for the ADA for 2021 or 22, you have the target of hypertension in 3 categories of person. Under 114 for reliable cardiovascular risk patient with 10-year atherosclerosis cardiovascular disease risk 15%. We have under 130 and 80 for high cardiovascular risk patient with existing atherosclerotic cardiovascular disease, and pregnant patient with diabetes and pre-existing hypertension. The target, it's between 110 and 135. And if we have a low risk, we have under 114 and 113 for the Canadian recommendation. So the patient characteristic and cardiovascular risk, it's an important point to consider when we have a choice for the target for blood pressure. If you take the latest recommendation of ADA in 2022, you have particularity for elderly diabetes with diabetes and blood pressure and dyslipidemia. The first category, when we have the healthy flu for patient, you have target under 114 for systolic and 19 for diastolic. The second target is for complex or intermediate with multiple coexisting chronic disease. In this case, we target less than 114 and 19 for diastolic. And then for the very complex or poor healthy, you have under 150 and 19 for diastolic. Now we are discussed the target for class antihypertensive. If you look at the published of WHO in 20 and 22, we have some questions, and the first one is at what blood pressure level should pharmacological therapy be initiated? The other question is the risk assessment needed to start therapy. And the third one is the discussion, it's about monotherapy or B therapy or combination of therapy. This is the target now. If you debate or if you speak of the ongoing debate as to which class of antihypertensive to prescribe, especially in patients with uncomplicated hypertension, this debate is continuing, but we have the choice with all the class of therapeutic, but we have some contraindication if you have pregnant, or if you have beta blockers, or if you have short-acting nifedipine and other, or renin-angiotensin system. And all these categories of class of antihypertensive will take in consideration the profile of patient and the contraindication and the side effect of this. But authors decide that we can show indifferently one of these if you have hypertension in complicated hypertension. You have to personalize the treatment of hypertension based on each patient complexity. And in this complexity, we have diabetes, we have coronary disease, we have heart failure, we have recent myocardial infarction, and all of these diseases or this comorbidity have an indication to choice a special class of antihypertensive. For diabetes, it's ACE inhibitors and ARB, and in the second choice, it's for CCB inhibitors, and finally the diuretic. If you have heart failure and you have the same classes with the choice, and we have myocardial infarction, we have beta blockers, and so you add 2 or 3 anti-classes, and you know that diabetes need more than 2 classes for target we have the good target or the ideal target for them. So the profile of patient or the complication or the comorbidities are a veritable indicator for the choice of class of therapeutic class in diabetes. And now we have the inhibitor, the SGLT2 inhibitor with insulin resistant, because individuals with insulin resistance and type 2 diabetes have a higher thresholds due to the upregulation of SGLT2 that increase proximal tubal glucose and sodium absorption, thereby contributing to hypertension and related cardiovascular disease. Recent large randomized placebo-controlled clinical trial have shown that treatment with SGLT2 inhibitors significantly reduced hypertension and cardiovascular disease event and present the progression of renal dysfunction in individuals with diabetes. What are the future perspectives? Insulin-resistant and diabetes increased the prevalence of hypertension. The underlying molecular and cellular mechanisms include inappropriate activation of the RAS and the SNCS, enhanced renal and endothelium sodium channel activation, mitochondria dysfunction, oxidative stress, inflammation, abnormal lysosomal myelin, abnormal gut microbiota, as well as increased renal SGLT2 activity. Treatment strategy in patients with hypertension with diabetes included lifestyle intervention and the use of the pharmacological therapy, including RAS blockade. Meanwhile, these patients may also benefit from treatment with GLP-1 agonist and SGLT2 inhibitors. And this is my conclusion. My conclusion is, although the discussion as to which antihypertensive to use in uncomplicated hypertension will continue to be deliberated, there is no disputing that patient outcomes are improved at lower levels of blood pressure. However, given the current state of affairs, we would improve patient outcomes significantly and more profoundly in the first focused on reducing blood pressure to appropriate levels and then targeted which class to use in patients with uncomplicated hypertension. And the major finding between January 2018 and March 2021 and their relevance to the management of hypertension has the potential to increase hypertension awareness, treatment and control with RB drug for the prevention of cardiovascular disease, morbidity and mortality in the future. And thank you for your attention.
Thank you very much, Professor Rashid Malik, for this interesting, comprehensive talk about antihypertensive agents for diabetic patients. Now we will present our third speaker, Professor Ala Bashir. He's consultant endocrinologist from Dubai Hospital. And his talk would be under the title, Anti-Diabetic Agents in Chronic Kidney Disease. Dr. Ala.
Thank you very much, Mr. Chairperson. It gives me a great pleasure to be with you today. And I'd like to thank the MENA Blue Circle Group for inviting me to be part of this event. My talk is basically about the management of diabetes in patients with chronic kidney disease. And basically, I'm going to focus on two classes of anti-diabetic agents. But before that, I'd like to start by just commenting on that diabetic kidney disease involves actually two types of kidney disease, as Dr. Hassanein mentioned. So we do have the non-albuminuric diabetic kidney disease, and in those patients there is a reduction in eGFR without changes in albuminuria, with normal albumin excretion. So as I said, we have two different forms of diabetic kidney disease. It's either a non-albuminuric chronic kidney disease, which is associated with a reduction or a decline in eGFR without albuminuria, while the diabetic nephropathy, the classical form, which has been mostly described in patients with type 1 diabetes, it presents with microalbuminuria, then it progresses to macroalbuminuria, and then it ends up with end-stage kidney disease. So what's the difference between the two? If we look at the non-albuminuric chronic kidney disease or diabetic kidney disease, this form has a slower trajectory to end-stage kidney disease. And it's more common in patients with type 2 than in type 1. And it's basically probably related to the use of RAS blockers, which reduces the hyperfiltration and reduces the albuminuria. So the typical pathogenetic mechanism or pathogenesis in patients with diabetic nephropathy, the classical form, is a glomerular hyperfiltration, which occurs early on, and there is usually around 25% increase in the glomerular filtration rate. That will result in glomerular hypertrophy, mesangial expansion, tubular hypertrophy, and that would result in enlarged kidneys, which is a hallmark of early diabetic kidney disease. Then hyperfiltration is usually followed by albuminuria, and that usually starts when albumin becomes between 30 and 300. And this is the typical pathologic appearance. If you look at panel A here, it shows a normal glomerulus, where in panel B, you can see that there is some nodular formation and nodular sclerosis, while in panel C, the typical or the classical Kimmelstein-Wilson nodule in diabetic nephropathy. It's important also, if you look at the panel down, the basement membrane, this is a normal basement membrane, and the one to the right is a thickened glomerular basement membrane. And this is a typical pathologic appearance in diabetic kidney disease. Now, what's the diabetic nephropathy continuum? It starts definitely with risk factors and diabetes or and other risk factors, and these will result in hyperfiltration. After the hyperfiltration and kidney involvement, there will be a moderate albuminuria that progresses to severe albuminuria, and that would later go into progressive chronic kidney disease and end-stage renal disease. What is the risk of diabetic nephropathy? With rising albuminuria, whenever the albumin, we go to microalbuminuria, albumin becomes between 30 and 300, and the eGFR starts falling independently, there is a definite increase in cardiovascular events and death. And for every halving of eGFR, there is a twofold increase in cardiovascular events. And with every tenfold increase in albumin excretion from baseline, there is a 2.5 folds higher risk of cardiovascular events. So as Dr. Hassanein mentioned earlier, the problem with patients with kidney disease and diabetes is not the renal impairment per se, but the main cause of death is cardiovascular events. And hence we need to handle their management into a multifactorial way. So the management, as I said, is basically multifactorial intervention. And whenever I say multifactorial intervention, I think most of us will go to the STENO2 study, where they started to look at multiple factor intervention in patients with diabetes. But the issue with the STENO2 study is that it has a very small sample size, and their A1C, the mean A1C at the end of the study was 7.9. So it wasn't a very intensive glycemic control. So I thought I will look at another study that looked at multiple or multifactorial intervention. And there is from Japan, the Japanese Diabetes Society did a study called JDO3, which was published in 2017. This is a study that included almost 2,500 patients with type 2 diabetes, and their mean A1C at the end of the trial was 6.2%. And in this study, multifactorial intervention has resulted in reduction in cardiovascular events. Not only that, it has also resulted in delaying the progression of diabetic kidney disease. So multifactorial intervention is very helpful in delaying progression of diabetic kidney disease. So when we treat a patient with diabetic kidney disease, there are a couple of factors that we need to keep in mind. Number one, we need to adjust the dose of most of the medications as the eGFR declines. And the second is that patients with chronic kidney disease are at higher risk of hypoglycemia. So we might need to use medications that reduces the risk of hypoglycemia in those patients. And the third issue is that not all the classes have proven renal or cardiovascular outcome trials. Many of them, actually, we had evidence for only 2 classes that has beneficial renal and cardiovascular outcome trials. Now, the third issue is that as time goes on, the kidney function actually deteriorates despite intervention with RAS blockers, with anti-hyperglycemic agents and antihypertensive agents. And then, especially in patients with transplant, there is always a drug-drug interaction. Many drugs do interfere with the anti-rejection medication. So I'm going to focus on 2 points. One of them is dose adjustment. And if we look at different classes, if we look, for example, at sulfonylureas, and we look at the glyburide and glibenclamide, their metabolites are not cleared by the kidney. And their metabolite in patients with kidney disease are not cleared, and then they accumulate and they increase the risk of hypoglycemia. So the risk is usually higher whenever the eGFR goes below 60. And the safest of all of them is glibizide, which is only 10% renally cleared, and it should be used just cautiously when the eGFR drops below 30. The other class is the glinides, and with the glinides, the natiglinide usually does not accumulate in patients with chronic kidney disease, but the metabolite of natiglinide do accumulate, and it can increase the risk of hypoglycemia. That's why it's not very much used, and it should not be used when the eGFR is less than 60. The most commonly used in patients with chronic kidney disease is repaglinide. And repaglinide actually is used frequently in patients with chronic kidney disease. I used to call it the basal bolus of the poor. When you don't want to go for 4 injections of insulin in a patient with end-stage kidney disease, you can start with a basal and give the repaglinide as if it's a bolus insulin with a reduction of the dose, minding that the patient might develop hypoglycemia. Now, what about the TZDs in patients with chronic kidney disease? I'm focusing on pioglitazone. Pioglitazone is not cleared and is not affected by the kidney function. It can be used safely in patients with kidney disease. However, there are 2 things you need to keep in mind. One of them is the fluid retention associated with pioglitazone. And the second is the bone disease associated with pioglitazone. Remember that patients with chronic kidney disease by themselves has a renal osteodystrophy. So that would probably add to the risk of bone disease in patients with kidney disease. So again, it should be used cautiously in patients with chronic kidney disease. With regard to DPP-4 inhibitors, this is a table that shows the dose adjustment in renal impairment. So whenever the eGFR is more than 50, you can use the full dose of any of the DPP-4 inhibitors. When there is moderate renal impairment between 30 to 50, we usually use half the dose with the exception of linagliptin. Linagliptin, we use 5 milligram across the board as it is not renally excreted. So it's not affected by changes in kidney function. Now, with regard to GLP-1, we have a couple of them that dose adjustment is not required, like dulaglutide and albiglutide, with also liraglutide and semaglutide. But the insert leaflet of the liraglutide and semaglutide says in stage 4 and beyond, it should be used cautiously. Exenatide, we should discontinue if it is below 30, and lixisenatide if it is less than 15. Now, with regard to GLP-1 agonists, we know that they have some renal benefits and cardiovascular benefits that I'm going to discuss in the coming slides. But now I'd like to focus mostly on metformin because in all guidelines across the board, whether patients with renal disease or no renal disease, they say metformin is the first line therapy. And in patients with chronic kidney disease, the worry is basically about the lactic acidosis associated with metformin. We all know that the risk of lactic acidosis is very rare. However, I just thought I'll go through a couple of trials that looked at the risk of lactic acidosis in patients with chronic kidney disease. And this is a trial that basically looked at the erythrocyte metformin levels in patients with chronic kidney disease. And they have found that there is mild increase in the green bars, mild increase in the levels of metformin and lactic acid in patients with stage 2, stage 3, and stage 4. However, it wasn't very significant increase, and the authors actually concluded that there is an increase, but that was a numerical increase, and it wasn't very significant, even in patients with stage 4 chronic kidney disease. Now, about the dosing of metformin, there was a study. This is a study that compared the metformin used in elderly patients with kidney disease, and they used different doses for metformin, 1,700 per day, and if the clearance for creatinine clearance above 60, and 850 per day when eGFR is between 30 to 60. And they found that if you use 850 milligram above an eGFR of 30, then it's safe, and there is no actually difference in metformin concentration between the two groups. And this probably was the base for the FDA note that metformin can be used until eGFR of 30, and below 45 we need to reduce the dose of metformin. So what about benefits of metformin? This is, we all know that the Swedish has the robust diabetes registry, and they looked at patients with different levels of renal dysfunction in almost 50,000 patients, and they tried to look for effectiveness of metformin in those patients. And if you look at the survival, the panel A here on the left side, if you look at the all-cause mortality and survival, survival was highest in patients where metformin has been used compared to other medications. And if you look at other benefits with regard to survival, acidosis, and infections, metformin usually was part of the medication. So I just want to draw your attention that this is a bit old study that was in 2012, before the introduction of GLP-1 and SGLT2. But it shows the benefits of metformin in patients with chronic kidney disease. Now, what about medications that has a role in renal protection? And I'm going to take you through the GLP-1. And this is a summary of the cardiovascular outcome trials of GLP-1. And if you look at the benefits that you can see, there is significant reduction in MACE in almost all the trials except with the exenatide. And the reduction in all-cause mortality was seen here with liraglutide, where there is almost 15% reduction in all-cause mortality and cardiovascular death. The renal outcomes of GLP-1 is not as compared to the SGLT2. The renal outcomes are basically derived by reduction in new onset albuminuria. So if you look at the composite renal outcomes, for example, in LEADER trial, there is a significant reduction where around 22% reduction in composite renal outcomes. However, that was mainly driven by reduction in microalbuminuria. And if you look at other hard endpoints, renal endpoints, it wasn't significant between liraglutide and the comparator. Now, what about SGLT2 inhibitors? The SGLT2 inhibitors, as you all know, has a very strong cardiovascular outcome program. And if you look at all the trials, the cardiovascular outcome trials, and you can see there is significant reduction in heart failure, and there is a significant reduction in MACE in the CANVAS and the EMPEREG program. And the EMPEREG, there was as well a reduction in cardiovascular death. If we look at renal outcomes in these cardiovascular outcome trials, it was significantly improved or reduced renal outcomes in the EMPEREG outcome program, in the CANVAS program, and in the DECLARE team, where there is more than 40% reduction in events on all these three programs. But I'd like to focus basically on dedicated renal outcome trials, and I'll focus on two. The most important one is the CREDENCE trial. The CREDENCE trial has included almost 4,000 patients with type 2 diabetes who are high risk, who has severe albuminuria, that's macroalbuminuria more than 300, with an eGFR between, mean was around 57, but they included patients with an eGFR of 30 as well. So the primary outcome of the trial was doubling of serum creatinine, end-stage kidney disease, dialysis, and death due to cardiovascular and kidney disease. So these were basically the primary, that was basically the primary outcome. And if you look, the primary outcome has been reduced by 30%. So hard endpoints has been reduced significantly using canagliflozin in the CREDENCE trial. Now, the end-stage kidney disease and dialysis has been reduced by almost 32%. And the number needed to treat is around 42 patients treated for around 3 years to reduce one event of dialysis. So basically, there were significant renal outcomes with the CREDENCE trial. Similar data were derived actually from the DAPA-CKD. The difference between the two studies is that DAPA-CKD included 32% of patients included in the study were non-diabetic. So, and the benefits, you can see there is almost 39% relative risk reduction of the primary endpoint, which is again a hard endpoint, not only reduction in microalbuminuria, it's cardiovascular death, end-stage renal disease, and sustained reduction in eGFR by more than 50%. And you can see there are more benefits where there is 44% reduction in composite reduction in eGFR decline and end-stage renal disease and renal death. There is 29% reduction in cardiovascular death and hospitalization for heart failure, and there is 31% reduction in all-cause mortality. So SGLT2 with these two trials, in addition to cardiovascular outcome trials, has shown significant renal benefits. But the question is, how do they achieve these renal benefits? And I found two studies, one of them in 2014 that looked at the benefits of SGLT2 inhibitors, and they concluded that the mechanistic way, the empagliflozin, when administered, it has reduced the renal hyperfiltration. And if you remember, when I was discussing the pathophysiology, we said there is glomerular hyperfiltration and there is an increase in eGFR. So the first thing they do, they reduce the renal hyperfiltration, and that will result in reduction in interglomerular pressure. Another study in mice, they found that the SGLT2 inhibitors actually reduces oxygen consumption in the renal tubules, and that reduces the hypoxia. But if I would like to summarize, there are many trials. If I would like to summarize it, I'll summarize it in this way. When we use the SGLT2 inhibitors, there is a reduction in eGFR. And the reduction in eGFR, if you look at step 1, will result in a reduction in renal oxygen consumption, reduction in albuminuria, and reduction in transport work. And with the reduction in glucose reabsorption, there will be a reduction in blood glucose that will result in reduction in kidney growth, albuminuria, and inflammation. The reduction in blood glucose as well will result in reduced need for insulin and increasing glucagon. Increasing glucagon will increase lipolysis, and that will result in mild ketosis, which is very beneficial to the kidney and the heart, and result in renal and heart protection. Again, the SGLT2 inhibition enhances the sodium hydrogen exchanger, which results as well in nitrolysis and uricosuric, and that will result in reduced extra vascular volume, and it results in reduction in uric acid levels and body fat and weight, and that again will have beneficial effects on the kidney. So this is the basic mechanism. Now, knowing these benefits and the mechanism of action, how does that translate in the guidelines? If we look at the guidelines basically, as with the ADA and the guidelines for general population, they mentioned that SGLT2 inhibitors has to be added to the anti-hyperglycemic medications regardless of baseline A1C. Okay, and all patients should be offered an SGLT2 inhibitor with a proven cardiovascular benefits, and that there is a reversible reduction in eGFR early on. It's around 10%. When we use RAS blockers, there is always around 30% reduction, but with SGLT2, it's around 10% reduction in eGFR. That is reversible on withdrawal of medications. And hence, again, that has been translated into the KDOQI guideline in 2020, where they said in any patients with chronic kidney disease, an SGLT2 inhibitor should be started as long as the eGFR is above 30. When if the patient is already on SGLT2 inhibitor and the eGFR dropped, you can continue with SGLT2 inhibitor until dialysis, and then we can stop it when the patient starts dialysis. And similar information or data has been provided by the ADA guideline in 2021, where they said SGLT2 inhibitor if there is atherosclerotic cardiovascular disease, and if there is a diabetic kidney disease and albuminuria, it's preferably to use an SGLT2 inhibitor. So I'd like to finish my presentation by just looking at the future directions, and this is the Fidelio trial discussing the use of non-steroidal mineralocorticoid inhibitors, mineralocorticoid agonists, the finerenone, and I'm aware that Dr. Nazar Atala is going to talk about it. So I'm going to skip talking about Fidelio trial, but I'd like to mention one thing, that even if there is an increased risk of hyperkalemia when we use the mineralocorticoid agonists, the use of potassium binders like sodium zirconium or patiromer, both are associated with significant reduction, and that would facilitate the use of these agents given their cardiovascular and renal benefits, as they do inhibit fibrosis as well. Now, one last thing I would like to mention, and this is something being the NRF2. NRF2 is basically a factor that has an antioxidant effect, and when it goes inside the nucleus, it actually reduces the oxidative stress, and it helps the cells to regenerate. So how does it work? When in normal situations, what happens, it binds the NRF2, binds to KEAP2, and that will facilitate the use or introduction inside the cell. But in cases of stress, the KEAP2 will go into transformational change, and that will cause degradation of the NRF2. So there is a drug called pardoxolone methyl that has been used to prevent the degradation of NRF2. And the pardoxolone methyl has been studied in a couple of trials. The first one was called BEAM trial, and that was phase 2 trial, where they found, and again, I would like to focus on this, not only preservation of kidney function, but improvement in eGFR. So, and this was a phase 2. When it was replicated in the PECON study, which is a phase 3 trial, there was increased risk of heart failure, but there is significant increase in eGFR. When they did a post hoc analysis for the PECON trial, they found that people who developed heart failure are those with a pro-BNP more than 200 and those with a previous history of heart failure. So they took it a step further in another phase 3 trial, and which called Tsubaki trial, where they excluded people with an BNP of more than 200 and those with history of hospitalization for heart failure, and they found significant increase in eGFR compared to the placebo, and it has been actually conducted in patients with lower stages of kidney disease, including stage 4 chronic kidney disease. So this is probably something going to help. Instead of saying we would like to maintain the kidney function, now in the future we're expecting molecules that would probably improve the eGFR in those patients. For bardoxolone, there is an ongoing trial called IAMI trial. It's being conducted in Japan. So in conclusion, Mr. Chairperson, I'd like to conclude by saying that diabetic nephropathy is the most common cause of end-stage kidney disease globally. The glycemic control may delay or revert nephropathy in the early stages, and the presence of CKD determines the type of oral agents that we should use. And once microalbuminuria develops and the eGFR drops below 60, RAS blockers and SGLT2 inhibitors are recommended unless contraindicated. And I'd like to say that there are many therapies in the horizon that may help tackle the residual risk as well as improve the eGFR in those patients. And this is my last slide. Thank you very much for giving me this chance.
Thank you very much, Dr. Ala, for this nice talk, especially that regarding the experimental drugs for patients with chronic kidney disease. And now the last speaker would be Professor Nizar Atallah. He's a clinical professor of medicine, Cleveland Clinic, Learners College of Medicine. He's consultant physician, nephrology, hypertension, and renal transplant medical subspecialties from Cleveland Clinic, Abu Dhabi. And his talk would be under the title, What is New in Chronic Kidney Disease? Professor Nizar, the floor is yours.
Thank you for the introduction, and thank you for including me in this program. It's very nice to hear endocrinologists talking about kidney disease. Dr. Ala did a great job in introducing this talk and talking about the pathophysiology of diabetic kidney disease. That will make my job much easier. So the definition of chronic kidney disease, and this was alluded to in the previous talks, you have to have either structural or functional abnormality in the kidneys, and that should persist at least 3 months to call it chronic kidney disease. And normally you have to have either decreased GFR, or you have to have albuminuria or hematuria, or on imaging you should see kidney cysts or hydronephrosis. All of these can point towards having chronic kidney disease. Of course, patients with kidney transplantation are by definition having chronic kidney disease because the kidney was replaced, even if they have normal kidney function or normal urine analysis. Just to remind you, the way we classify chronic kidney disease, you're all familiar with this. In the past, we used to look at GFR only, and we classified the patients into 5 stages. Very quickly, we recognized the importance between and separation between patients GFR 45 to 60 and 30 to 44. So we separated that into 3 and 3B. But we also recognize the importance of albuminuria towards outcomes. So that's why we added albuminuria to the classification of chronic kidney disease. And the major reason for this is you can have a patient with GFR of 70 and have macroalbuminuria. This patient almost have the same risk of cardiovascular event of somebody with half of the GFR, 35, and no albuminuria. So it's very important to check for albuminuria and follow it. It's a very strong predictor of endothelial dysfunction and vascular complications. When we look at end-stage renal disease, patients starting on dialysis today, 50% of them or more, the kidney failure is related to diabetes. It's a very important disease that's contributing to patients starting dialysis, and we need to control diabetes well and slow down the progression of chronic kidney disease, and we need to use the right medications like Dr. Ala alluded to be able to slow down the progression of kidney disease and preventing dialysis. We know that there are millions of patients with diabetes, about 463 million patients with diabetes in 2019. And most of these patients had type 2 diabetes, about 90% of them. And we know that chronic kidney disease, depending on the study, anywhere between 15 to 40% of patients with diabetes will end up with chronic kidney disease. Estimated about 160 million globally have chronic kidney disease with type 2 diabetes. And very importantly, that patients with chronic kidney disease, as they progress, the risk of having cardiovascular event and dying is much higher than the risk of going into dialysis. Now, this is the NHANES study. This is a prospective observational study. It gets repeated every few years. They collect data for about 3 years for almost every decade, and they start comparing them. And as you see here over the years, that the incidence of chronic kidney disease is increasing, especially with the higher stages. But very importantly, you see the huge drop in patients between CKD3 and CKD4. And this is mostly because a lot of these patients die, mostly from cardiovascular events, and they don't end up getting more progression and ending up on dialysis. So we need medications and therapies to improve the cardiovascular outcomes in CKD patients. We know that GFR is a very strong predictor of hospitalization, of cardiovascular events, and death from any cause. This is not a cause-effect relationship, but it's a very strong association between GFR and all of these outcomes. The lower the GFR, the worse all of these outcomes. Also, we know very strong correlation between albuminuria and all-cause mortality and cardiovascular mortality. The higher the albuminuria, especially once you pass the point of microalbuminuria, the higher the risk of all-cause mortality and cardiovascular mortality. We also know that chronic kidney disease is a strong predictor of all-cause mortality. If you see on the right side of the slide, the reference group, no diabetes, no CKD. Diabetes for sure increases the risk of all-cause mortality. When you have CKD, it almost doubles the risk of having diabetes. And when you have diabetes and CKD, the risk is much, much higher even than having CKD alone or diabetes alone. In fact, it's almost double the risk of dying from a previous MI. This is a very important combination of diseases that we need to address and slow down. When we look at cardiovascular mortality in dialysis patients have huge vascular problems, especially vascular calcification, inflammation, oxidative stress, so their cardiovascular mortality is very high. In fact, a patient in their mid-20s on dialysis almost have the same mortality of somebody in the general population in their mid-80s. Just to give you an idea how sick those patients are and how high their mortality is. There is very strong interrelationship between diabetes, heart failure, and chronic kidney disease, mostly due to the factors that were mentioned in the previous talks. We'll touch base on those factors in a little bit, but we know type 2 diabetes will increase almost 50% globally in our area, probably 100% over the next 20-25 years. Diabetes patients are at 5 times risk higher to develop heart failure. And we know heart failure patients have very high mortality, almost 50% within 5 years after diagnosis. Also, those patients, depending on the study, anywhere between 15 to 40% diabetics can develop chronic kidney disease. And chronic kidney disease patients, they have 10 to 20 times higher risk of cardiovascular disease if you compare it with the general population. Very, very strong relationship between all of these 3 factors together. That's why we developed the cardiorenal metabolic syndrome that addresses all these disorders together. Now, as a progression, initially albuminuria will start increasing. Of course, GFR in the beginning might go up as a sign of hyperfiltration that causes glomerular hypertension and then slowly starts going down. This is how it used to be in the past. Now we have new paradigms that we notice sometimes GFR would go down even without albuminuria in diabetic patients. Also, we have patients that have progression and regression of albuminuria. This is mostly because we have newer agents to address diabetes, better agents to control diabetes, and also the use of RAS inhibition is very ubiquitous these days that will change the progression of diabetic kidney disease. ADA in 2021 recommended that any patient with type 1 diabetes for more than 5 years or any patient with type 2 diabetes deserve to have their urine albumin checked and GFR checked at least once annually. And if their GFR is under 60 or they have abnormal urine albumin, they need to be checked at least twice a year. Sometimes in my practice, because I see sicker patients, we check it 3 or 4 times depending on their degree of kidney function. But it's very important to do this. In fact, observational studies looking into this finds that almost 50% of patients across the world in different countries, even in developed countries, do not have the screening done in diabetic patients. And over the years, there are different studies that were done to try to address the issue of diabetic kidney disease and slow it down. We know ACEs or ARBs are well studied. They improve outcome in chronic kidney disease patients, whether it's diabetic or non-diabetic. The combo of ACE or ARB is not helpful. There are other families that were studied, anti-inflammatory medications, direct renin inhibitor, all of these were negative studies. Bardoxolone, the Beacon study, Dr. Ala alluded to it. There was improvement in GFR, but unfortunately, the heart failure incidence was higher. So this medication, at least for now, is not available for treatment, although there are other studies that are being done, like Dr. Ala mentioned. And just to remind you, these are the ARB studies, very famous studies. Renal study looked at about 1,500 patients with type 2 diabetes and chronic kidney disease, and clearly showed improvement in the progression of kidney disease when we look at doubling of serum creatinine, requirement of dialysis or death. In the same issue of the New England Journal of Medicine, you have the IDNT study, which is the irbesartan study, about 1,700 patients. Similar outcome. Irbesartan was compared here against placebo and against amlodipine, and also there was significant improvement even when you compare it against amlodipine. In the renal study, losartan was only compared against placebo. But we know that there is a residual risk even with using those medications. So we have room to add other medications to help slow progression of diabetic kidney disease. Of course, people started looking at SGLT2 inhibitor, especially when we had the secondary kidney outcome results from the cardiovascular outcome trials, the EMPEREG, the CANVAS, and the CLARE. So CREDENCE was the first renally specific study in SGLT2 inhibitor looking at canagliflozin use in CKD patient. It went down to GFR of 30. It included patients only with macroalbuminuria. Everybody had to be on a RAS inhibitor, included only type 2 diabetes patients, about 4,400 patients, and clearly the result was positive. So that was the first study that was done. Then DAPA-CKD came. DAPA-CKD expanded the use of SGLT2 inhibitors, so it went down to GFR of 25, included patients with microalbuminuria, 200 and above, and also included diabetic and non-diabetic. Very nice positive results also, both in diabetic, non-diabetic, across the board in different GFR levels. EMPA-KIDNEY is a third renal specific study in SGLT2 inhibitors. We're very excited that the study was stopped early recently because of positive outcome. We don't know the results yet. They should be published, we are told, in November in the American Society of Nephrology, but we are told that it's positive results, just like CREDENCE, just like DAPA-CKD. EMPA-KIDNEY included patients with lower albuminuria, also went down to GFR of 20, and included diabetics and non-diabetics. So it will expand the use of SGLT2 inhibitor in kidney disease patients. Now, Fidelio and Figaro is looking at a newer family of medication, finerenone, MRA. We'll discuss them in more details in a minute. And then the FLOW study is expected to finish in 2024. This is looking at semaglutide, looking specifically at the renal outcomes as primary outcomes. So we'll see what that will show. Now, just to show you what happens, we know in diabetic kidney disease, there is glomerular hypertension, there is usually efferent arteriolar vasodilatation and efferent arteriolar vasoconstriction. So when you use an SGLT2 inhibitor, it causes efferent arteriolar vasoconstriction. It lowers glomerular pressure, and with this, it helps to slow down the progression of kidney disease. Now, when you use a RAS inhibitor, it causes vasodilatation of the efferent arteriole, and this also causes lower glomerular pressure and reduction in albuminuria, and slowing down diabetic kidney disease. Now, in the SGLT2 renal specific studies, Credence, EMPA-KIDNEY, and DAPA-CKD, we're combining SGLT2 inhibitors and RAS blockade. So we're causing vasoconstriction of the afferent arteriole and vasodilatation of the efferent arteriole. So we're lowering the glomerular pressure even more. Some people had concern in the beginning, well, maybe there is higher risk of acute kidney injury, but that did not show in any of the major studies that was done, and actually slowed down the progression of kidney disease more. So I'm just going to show you the few curves from the DAPA-CKD, then we move forward. This is a DAPA-CKD primary composite outcome, which was sustained increase more than 50% in GFR, decline, or development of kidney failure requirement dialysis, or death due to renal or cardiovascular death. Clearly, the DAPA arm had better outcomes, and the curve separated about 6 months. Very, very nice separation. And then when in the DAPA-CKD, in fact, dapagliflozin also lowered all-cause mortality in those patients. Although these are high-risk patients, all-cause mortality separates also at about 6 months. Very important. This was secondary endpoint, though. Now, despite using RAS inhibitor and SGLT2 inhibitor, you still have residual risk. You look at the Credence study on the left side of the slide and the DAPA-CKD on the right side of the slide, the residual risk is still significant. There is room to add other medications to help slow down the progression of kidney disease and improve outcome for those patients. Now, just to take you back a little bit to the pathophysiology, inflammation, fibrosis are key drivers for chronic kidney disease. We know diabetic kidney disease is very complicated. There are a lot of pathophysiological factors that will contribute to this, but mostly there are hemodynamic factors, metabolic factors, and inflammation and fibrosis factors. And all of these will cause tubular interstitial damage, and inflammation will cause glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and slowly kidney fibrosis happens, the progression of chronic kidney disease will happen. Now we have medications to address the hemodynamic factors. So we have RAS inhibitors, we have diuretics, even SGLT2 inhibitors have hemodynamic effect to lower the intraglomerular pressure. SGLT2 inhibitors and GLP-1 specifically, they address the metabolic issues, but any medication that controls diabetes better helps to slow down the progression of diabetic kidney disease through the metabolic pathways. Now, inflammation and fibrosis, unfortunately, so far, we do not have good studies. We were excited with the bardoxolone initially, but the excitement faded away when the heart failure results came out. So we don't have really medications to target this part of the pathophysiology. Now, we know that mineralocorticoid receptor overactivation increases oxidative stress, stimulates several pro-inflammatory cytokines and pro-fibrotic mediators, and that can induce inflammation and fibrosis. This targets the kidney, the vasculature, and the heart, can cause glomerular damage, proteinuria, tubular injury, and reduced renal blood flow. It can cause also vascular remodeling and endothelial dysfunction and stiffness in the vasculature. Also, it can cause heart damage, myocardial hypertrophy, ventricular remodeling and fibrosis, and reduced coronary blood flow, plus ischemia. So the overactivation of the mineralocorticoid receptor has very, very bad effects. Also, we know albuminuria is correlated well with glomerular basement membrane width, with mesangial expansion, with glomerular volume, and sclerosis of the glomeruli. The higher the urine albumin, the higher the incidence of those. So as we said, we have ways to address the hemodynamic and metabolic pathways, inflammation and fibrosis. Now, with the only pathway we have is blocking the mineralocorticoid overactivation. And we know this for a long time. We know the RAL study was done a long time ago. FSS was done with using eplerenone. These are in heart failure patients. Clearly, the mortality is better. Also, we know that spironolactone and even eplerenone, they help to lower proteinuria and actually slow down the progression of chronic kidney disease. These are several studies looking at that. This is a meta-analysis. In fact, about 30% drop in albuminuria when we use spironolactone on top of RAS inhibitor. This is another study, also effect of adding spironolactone. Exactly similar effects happen with eplerenone. The major problem is side effects, specifically hyperkalemia. In fact, with the online publication of the RAL study, the incidence of visits to the ER with hyperkalemia increased immediately, even before the actual publication came out. When people started using spironolactone. So this is a big fear. Patients are getting to the ER with high potassiums, high risk of arrhythmias and death. So this was a big problem that prevented people from writing spironolactone or eplerenone for patients. Now we have the newer agent. Finerenone is a non-steroidal mineralocorticoid receptor antagonist. It has much less side effects, specifically less gynecomastia, less hyperkalemia, and it has much higher capability of binding to the mineralocorticoid receptor, so it has much higher specificity. So it was studied in two major studies, the Fidelio and the Figaro. The combination of both studies, more than 13,000 patients. It's a multi-center, multinational studies. Fidelio included about 5,700 patients. Figaro included about 7,400 patients. And the design is almost the same. Included patients with microalbuminuria, 30 to 300 or even more, and GFR of 25 to 75. Both studies included the same population. Fidelio looked at kidney outcomes as primary outcomes and cardiovascular outcomes as secondary outcomes. Figaro was the opposite, looked at cardiovascular outcomes as primary outcomes and the kidney outcomes as secondary outcomes. You might say, you know, they're the same, but when you calculate the power and the incidence, it's a little bit different. You need more patients, especially in diabetic kidney disease patients, to prove improvement in cardiovascular outcomes. And this is just a distribution, as you see in Fidelio, included more patients with macroalbuminuria, less with microalbuminuria in comparison with Figaro. Figaro almost half macro and microalbuminuria. And then when you look at the GFR distribution, Fidelio for sure included lower GFR. So more than 50% of patients had GFR under 45, which is what we wanted to study this sicker group of patients. Figaro, because they were looking specifically at the cardiovascular outcomes, included patients with higher GFR, above 60, almost 60% of the patients. So the Fidelio and the Figaro looked at patients with microalbuminuria, macroalbuminuria, GFR 25 to 75. We know Credence that we mentioned, 4,400 patient, macroalbuminuria only, GFR down to 30. DAPA CKD, almost same design like Fidelio, Figaro, but had lower microalbuminuria, 200 and above. And the EMPA kidney will go down to GFR of 20. Initially, they wanted to include patients of microalbuminuria and higher, 30 and above, but then because of COVID, they were not able to recruit enough patients, so they restricted to 200 and above. And as you see, when you compare Fidelio Figaro program across the other programs, you see the number of patients is much, much higher, and we have excellent results from it. So as I mentioned earlier, Fidelio looked mostly at kidney outcomes as primary outcome. Figaro looked at cardiovascular outcomes as primary outcome. So this is the design of the Fidelio. Figaro is almost the same. There was a run-in period to make sure they could tolerate RAS inhibitor, and it's optimized. And then they added finerenone versus placebo, 10 milligram or 20 milligram, depending on the GFR. I'll mention this in a little bit. And then there was post-treatment follow-up. It went up to about 2.6 years median follow-up. And when you look at the distribution of the patients, they were almost the same between the two groups. Mean age of about 65. Hemoglobin A1C 7.7, relatively controlled diabetes. It's not so bad. I just want to show you that SGLT2 inhibitor use was very low in both, in the Fidelio and Figaro, less than 5%. And the reason is that those studies were designed even before EMPIRIC was published. And that's how the design continued. So they did not have a lot of patients with SGLT2 inhibitor. We'll address this at the end. GLP-1 usage was also not high. And then when you look at the distribution of the GFR, the albuminuria, and the use of RAS inhibition, almost the same between both groups. Look at the blood pressure control is almost the same, and the distribution of blood pressure medication is almost the same. I just want to show you here, diuretics were almost 55, 57% in both groups, because finerenone has some diuretic effect, so it was added on top of other diuretics. And clearly, it will significantly reduce the risk of composite kidney endpoint, as you see. When you look at sustained drop in GFR, more than 40%, or renal death, it was better with the finerenone group versus the placebo group. And then when you look at the primary composite outcome, and then you distribute it to the different components, whether requiring of dialysis, sustained decrease in GFR, or having GFR less than 15, or renal death, across the board, it was better in the finerenone group versus placebo. And then when you look at the different subgroups, whatever the GFR was, whatever the baseline systolic blood pressure was, whatever the hemoglobin A1C was, there was benefit of using finerenone in comparison with placebo. The only group was the patients who had GFR of 60 at the time of screening. They did not have benefit from finerenone. But even when you look at baseline GFR, when they were included in the study, when it was above 60, there was benefit. And clearly albuminuria improved. When you look at the different components, finerenone was better than the placebo group. And also just to prove that the secondary outcome in the study, which was the cardiovascular outcomes, also were better with finerenone in comparison with placebo. Now, and this is a distribution of the different components of the cardiovascular outcomes. We're looking at cardiovascular death, non-fatal MI, hospitalization. All of them were better, although they crossed the line of unity. Non-fatal stroke was not different between both groups. And then when you look at side effects, whether you look at any side effect or serious adverse events, acute kidney injury, gynecomastia, they were very similar between the finerenone and the placebo group. In fact, gynecomastia, you see very, very low percentage if you compare it to spironolactone. And then when you look at adverse events specifically related to hyperkalemia, much, much less than spironolactone. Still, it was a little bit higher than the placebo. The incidence of hyperkalemia leading to permanent discontinuation of the drug was very low, 2.3%, and leading to hospitalization was only 1.4%, much, much less than spironolactone and eplerenone. So this is a very big improvement with this medication, and it will help us optimize using this group of medication on top of RAS inhibitors. And then they had a very nice algorithm how to address hyperkalemia. So first, if somebody had a GFR under 60, they started with a 10 milligram dose. If it was above 60, they start with the 20. They check potassium at 1 month. And if it was normal, they'll check it again at 4 months. If the potassium was elevated, they check it monthly. They will not increase the dose unless the potassium was less than 4.8. If the potassium was 5.5, they will withhold the medication for 72 hours and then repeat the potassium. They will not restart the finerenone unless potassium was less than 5. So they had very nice algorithm how to walk us through addressing hyperkalemia when it happens with the use of this medication. Now, Figaro study is similar design as I showed you earlier, looked most at cardiovascular outcomes as primary outcome. I'm showing you here only the slide for the kidney outcome, which was secondary, but also showed the same. There was better kidney outcomes with using finerenone versus placebo. So in summary of those studies, this is a first positive long-term phase 3 study looking at the use of non-steroidal MRA in broad patients population with diabetic kidney disease, patients with lower GFRs from 25 and higher, patients with microalbuminuria, macroalbuminuria across the board. They had kidney outcomes and cardiovascular outcomes that were better than placebo. Also, this is a novel mechanism of action on top of optimized RAS blockade and relatively controlled hemoglobin A1C and blood pressure. And the side effects were much less than other MRAs. Gynecomastia was much less, hyperkalemia was much less, admissions to the hospital or visits to the ER with hyperkalemia are much, much less. So this helped us to continue the medication and optimize the care of the patient. So that's one of the reasons the ADA in the recent addition, they actually recommended using finerenone as an alternative to SGLT2 inhibitor. If there are patients who cannot tolerate SGLT2 inhibitor or are allergic to it, then finerenone can be considered for those patients. I'm sure with time and more studies, even finerenone will be used more and more in diabetic kidney disease, and it will have its place in the guidelines. The KDIGO now are thinking of adding finerenone as an add-on to SGLT2 inhibitor, although still these guidelines are in progress. And then some practical future issues that people are thinking about. Okay, so what's this role of finerenone? Are we going to use it in replacement of SGLT2 inhibitors or as an add-on? There is an ongoing study called the Confidence CKD, finerenone versus empagliflozin versus a combination of empagliflozin and finerenone. I will see what that will show. we're hoping the combination will have better results, because we know in the DAPA-CKD study, when there are a group of patients that were on MRAs, and when they are compared with a group of patients who were not on MRAs, the outcome of using dapagliflozin on top of MRA was better than not using MRAs. Of course, those patients were all on spironolactone, but hopefully with finerenone, with lower side effects, we'll have better outcome and we can use those medications more. Also, how about the use of finerenone in non-diabetic CKD? There is also another ongoing study called the FIND-CKD, and if this becomes positive, this will expand the use of finerenone also to the non-diabetic CKD, just like we had in DAPA-CKD, and we're hoping to see in the IMPACT-ME study. And I would stop here and would be happy to take questions. Thank you.
Thank you very much, Dr. Nazar Atallah, for this extensive talk about antihypertensive, anti-hyperglycemic agents that have protective effect for the kidneys. Now we will start the session of questions. First question, what from Fatma Abdullah, what happened to hemoglobin A1C in patient with chronic kidney disease stage 3 and less? What do you mean by stage 3 and less? You mean stage 4 and 5 or what else? I don't know. But this is the question. Who will respond?
Was this specific to finerenone or controlling diabetes in general, or I'm not sure.
No.
Well, I might comment that in patients with chronic kidney disease, there are many issues with using hemoglobin A1C, and that would include definitely if the patient had anemia, if they're using erythropoietin, and this usually in patients with lower stages of chronic kidney disease, stage 3B and 4 and 5. Yes, it might not be very accurate measure in those patients. However, it is still in the guidelines that A1C should be used to monitor the glycemic control. But when it comes to patients with advanced stages of chronic kidney disease, stage 4 and 5, it's always preferable to use A1C with self-monitoring of blood glucose. Self-monitoring of blood glucose in stage 4 and 5 is very essential because it tells you exactly how high is the fasting and postprandial glucose. So if you're going to use A1C, use it in combination with self-monitoring of blood glucose. Don't use it alone.
Also, assuming that probably she's asking about what happened to hemoglobin A1C in the SGLT2 studies with CKD less than CKD3. Because, you know, when you use SGLT2 inhibitors, when you have a GFR less than 45, the glycemic control disappears, and you know there is no glycemic benefit, but you still have cardiorenal benefits. So I'm assuming probably that's part of the question too, that you know with the SGLT2 inhibitor, if you use them within patients with GFR 45 or less, you don't give a benefit of diabetes control, but you still slow down the progression of kidney disease and lower cardiovascular events. That might be, I'm not sure, maybe she's also asking about this.
The third attempt of answering the question is how good is the HbA1c in those with stage 3 and beyond? As I've shown, eGFR below 60 is stage 3 and beyond, and only 50% of our cohort had HbA1c below 7, and the rest were above 7. So here you have 3 different answers for the questions.
Okay. Next question from Dr. Tasneem Yahya. In calculating estimated GFR, what is the best formula, Dr. Nazar?
So mostly we use EPI-CKD now. There are different formulas that you might find, Cockcroft Gold, MDRD, but EPI-CKD is probably the most comprehensive one. Most labs actually will generate eGFR for you now. You don't need to even calculate it. But if your lab does not do it, there are a lot of free calculators available online. I use typically the National Kidney Foundation in the US calculator. It's free. You can just actually download the app on your phone or put it on your desktop. this is the most accurate one. Now, there is an addition to the EPCKD recently, over the last year or so, where they removed the race part from it, especially African Americans. We had to adjust before, but we don't adjust anymore. But this is not important for our region. But EPCKD is probably the closest to the real creatinine clearance. So that's mostly the one that we use.
What about the Cockcroft-Colt equation? Is it obsolete?
So in practice, it is obsolete. The problem is that a lot of this pharmacological studies of dosing medications were based on the Cockcroft-Colt. So pharmacists still use Cockcroft-Colt to dose different medications. Like in our hospital, we use electronic medical record. Still, the pharmacist use the Cockcroft-Colt. Now, a lot of companies are doing redosing study according to the EPCKD. This is still happening. It will take time. For clinical practice, I would not use Cockcroft-Colt. There is a lot of problems with it, especially in women, people with lower body weight. Also, obese patient, it does not estimate the kidney function well, but we still use it only in dosing of medication because most of these dosing studies were done based on Cockcroft-Colt.
I would expect that the answers would be very short because we have too many questions. The next question from Ishtiyaq Shafi: does ethnicity have any influence on CKD in diabetes and hypertension?
I can take this question because I did this section of the epidemiology. In many ways, yes. So two aspects here, ethnicity and hypertension and CKD. So we know that Black Africans have higher rates of hypertension and different response to different antihypertensives. But more importantly for our population, as I've shown in our data, the prevalence of CKD is lower than Western population because of the younger age group. The people I see here in UAE with diabetes many of them are in their 30s and 40s, where the vast majority of the patients I used to see in UK were in their 60s and 70s. So consequently, the prevalence is a bit different from the Western society.
Dr. Muhammad, also probably there is some familial incidence for the CKD in a diabetic patient and hypertensive patient, because we have seen many families. The whole family are having CKD very early after developing diabetes mellitus, while many families on the other side, in spite of the very long duration of their disease, but still they are having normal or near normal renal function.
This is very true. Obviously, there are some genetic predisposition. But what I'm thinking of is the things that we can think of in general for the whole population, or the things that we can alter ourselves. We cannot really change very much my genetics, but knowing that a person in front of me in clinic is young, they might not have the condition now, but they're going to live with diabetes for many years. So it's crucial that we can get the risk factors controlled and being treated with the right type of therapy.
I mean, I agree. There is a gene, well-known gene called APOL1, and there are different penetrations of this. It's the bad penetrance of APOL1. It's more in African Americans and Hispanic, and that's why we see more diabetic kidney disease in those patients. There is also familial predisposition specifically to this one. It's called APOL1. And but as Dr. Hassanein said, this is genetic, and so far we don't have ways to address this. Although there are studies now looking at modifying this gene to see if it lowers the progression of diabetic kidney disease. Still, these are in early stages, though.
Sabrina Bouzerdour, she's saying hello to Professor Hassanein, and she's asking, what are the therapeutic regimes that you recommend in renal insufficiency with creatinine clearance less than 30? I think
I would divert this question to Dr. Ala and Dr. Atallah as both
exactly
with these patients, and they covered it in their presentation very well.
Yeah.
With regard to medications, oral hypoglycemic agents below eGFR of 30, out of the sulfonylureas, the gliclazide or glibizide, as they call it in US, is the safest, but it has an increased risk of hypoglycemia. So if you would use it cautiously. But we have other medications, like you can use a repaglinide for postprandial hyperglycemia. You can use TZD with caution, but the safest below the eGFR of 30 is always insulin.
Dr. Ala,
and the GLP-1 analogs can be used as well below the eGFR of 30.
Dr. Ala, you mentioned in one of your slides the sulfonylureas, glyburide and glibenclamide. In fact, they are one drug. Glyburide, glibenclamide in USA, they are calling it glyburide, and other parts glibenclamide. So just to make it clear.
DPP-4 inhibitors can be also used. Of course, some of them you need to cut down the dose. Linagliptin, for example, you can go down to very low GFRs without changing dose. Less, they're weaker as glycemic agents.
Yeah. Okay. Yahya bin Ammar, he's asking, diabetic patient type 1 or type 2 on insulin therapy with microalbuminuria beyond 300 milligram per 24 hour are fasting, that is to say fluid restriction between two brackets for 30 days during Ramadan, affects kidney function? Does it affect kidney function?
On microalbuminuria, I had that question several times with colleagues from Egypt as well, and they were asking whether microalbuminuria should be one of the risk parameters for the calculators, but we do not know for short-term 30 days of fasting. We looked into the eGFR and microalbuminuria in our cohort, in our study that we did, myself and Ala, in our stop in hospital in Dubai, for patients with impaired renal function, and there was no significant change. Marginal change at the end of Ramadan, which reverts back 2-3 weeks later. So with microalbuminuria, I'm not really sure that it will affect the person's ability to fast. Now, the ability to fast is related to another number of accumulative factors, the type of therapy the person is on, other comorbidities, the frequency of hypos, and all of these issues. So it's not of a yes or no. We need to look into the risk calculator of the added layers and factors that will make you eventually say, okay, perhaps my eGFR is 58 and I'm on metformin only or DP4 inhibitor and I have no other problems. And perhaps I have plenty of other conditions and frequent hypos and treated with intensive insulin. So it's only one parameter, which is the renal issue. And specifically here is the renal issue is only microalbuminuria and not a reduction in eGFR where dehydration or electrolyte imbalance would play a role.
And one point, I think it is the estimated GFR is the most important factor in deciding whether to fast or not.
Yeah.
Because definitely Dr. Nazar can tell this, that the healthiest kidney is that when you have good hydration of the kidney. So you may have deterioration in the renal function whenever the kidney is exposed to any degree of dehydration. Isn't it, Dr. Nazar?
Yes, I agree with Dr. Muhammad Hassanin comment. Individualization is very important. You have to look at multiple factors. The GFR is probably the strongest and most important when you look at renal patients. But you have to look at the medications they're using. You have to look at other comorbidities. In general, for us, the fasting in renal patients is not very well studied, but as Dr. Hassanin mentioned, the albuminuria is not a very important predictor. GFR is much more important. In general, in our patients, when GFR is above 60, we do not have any issue with fasting, especially if they do not have other major comorbidities. 45 to 60, we allow them to fast. but we give them the option not to fast. So it's better to do it, but it's okay not to fast, especially if they had previous hypoglycemias or hypervolemia or hypovolemia in the past. GFR 30 to 45, we normally advise them not to fast, but they have the capability of fasting. Most of these patients, we ask them to repeat their kidney function 5 to 7 days after the beginning of Ramadan to make sure that the kidney function does not get worse. And if it does, we tell them to stop. And then if GFR is under 30, most of the time we tell them not to fast because there is higher risk of progression of kidney disease and requirement of dialysis. Now, this is based more on expert opinions. This is not very well studied, but this is most nephrologists will agree on this.
And you will have that precisely matching the risk calculator that we have for the levels of risk according to the eGFR. So it's not one figure. Below 30 is 6.5 points, which clearly put the patient into red. Between 60 and 45 is a different number compared to between 30 and 45. So, and when you add to it the therapy and the other issues, it makes the picture a lot more clear.
Again, from Sabrina Bouzardour, in type 2 diabetic with heart failure and renal failure, how dapagliflozin treatment is monitored? In a type 2 diabetic with heart failure and renal failure, how dapagliflozin treatment is monitored?
If we look back at the study, the DAPA-CKD, we had patients with advanced stages of chronic kidney disease, even those with an eGFR of 20. They have albuminuria like A3, significant albuminuria. Dapagliflozin has resulted in significant benefits, renal and cardiovascular, with reduction in heart failure. Now, whenever we start an SGLT2 inhibitor, whether dapagliflozin or any other SGLT2 inhibitor, we would expect a drop in eGFR. But that should not be a reason for discontinuation of medications. The only thing probably you will need to monitor if there is a significant reduction in eGFR more than 10 to 20%, or there is repeated urinary tract infections. Otherwise, with DAPA, there are not much of side effects that you probably need to look
for. Professor Malik from Mahartallas, why till now the third generation beta blocker action on nitric oxide endothelial system vasodilating properties has not gained popularity in treating hypertension in diabetics?
Well, Professor Malik is not with us, but I suppose the response would be the lack of evidence. If we have the evidence in studies, then probably it will be utilized.
Yeah. Okay. Again, from Mahartallas or from Mahmoud Fode, can we start ACE or ARB regardless to the baseline serum creatinine?
I guess I can take this one. So there are studies on using RAS inhibitors even with higher creatinines. There is a study looking at benazepril in patients with higher creatinine. That study had 3 groups of patient. Group 1 had creatinine of 1.5 to 3. We're talking about milligram per deciliter, or about 150 to 250 micromole per liter. Group 2 had the creatinine of 3 to 5, which was about 250 to 450. Group 1 and Group 2 were given benazepril. Group 3 also had a higher creatinine, 3 to 5 milligram per deciliter, or 250 to 450 micromole per liter, just to see the benefit. Of course, when you look at the study published in the New England Journal of Medicine, I forgot the acronym of the study, but clearly when you use benazepril at lower stages of chronic kidney disease, lower creatinines, you have the most benefit. But then when you compare Group 2 and Group 3, these are more advanced kidney disease patients. Group 2 had benazepril, Group 3 did not. There was clearly better outcome in terms of chronic kidney disease progression, in terms of hospitalization, and also mortality. All of these were less even when you prescribe benazepril to patients with higher creatinine. In general, in our practices, we continue RAS inhibitors even with very low GFRs, as long as the patient is not hyperkalemic and the progression of the kidney disease is not fast, the GFR is not dropping very fast. We like to continue RAS inhibitors, mostly because of their cardiovascular benefit. Even if we stop it when the patient is down to GFR of 12 to 15, once the patient starts on dialysis, we reintroduce RAS inhibitors because of their cardiovascular benefits.
May I make a comment, please?
Yes.
I think these type of patients are best treated in a specialist clinic where either there is a nephrologist or a diabetologist with interest in the topic for the careful handling of the changes in the electrolytes and the renal functions and so forth. So the advice really for these type of patients is to refer them to these specialists who would be able to handle these issues, because the dynamics of changing and perhaps what happens when a person have volume depletion with diarrhea or gastroenteritis or vomiting or something like this are really quite important, and they need to be handled with care rather than in a generalist clinic or with someone who doesn't have the skill and expertise of handling these drugs in such a critical scenarios.
When the estimated GFR is less than 30, what are the antihypertensive medication we should consider in a hypertensive patient? I think already answered this question. Yeah. What are the best or preferred oral hypoglycemic agent which can be? This is very general. Also, one of the colleagues, Maher Tallati, mentioned you, Dr. Ala, about the glyburide and the glibenclamide. He mentioned that it is almost the same drug. What is the maximum dose of metformin and GFR?
Well, I'll take this. We can use metformin at a maximum dose. Generally, in different countries, the maximum dose in normal kidney function is around 2.5, and in UK they use up to 3 grams of metformin. When the eGFR drops below 45, we need to half the dose, and when it drops below 30, we need to stop metformin.
Okay. When the estimated GFR is 50, should I reduce the dose of metformin patient on 2 grams daily? This is very 50, specific.
I guess it's fine to carry on with metformin. If it drops below that, we can reduce the dose.
I think less than 45, the dose has to be reduced, right? Yes. And at the estimated GFR, when it would be less than 30, then you have to stop it.
We stop metformin
altogether. And how frequent should we screen for CKD in patients with obesity and family history of CKD?
I guess it depends on their kidney function to start with. If their kidney function is normal, once every year will be enough. If they have major changes in their weight, for example, after bariatric surgery or with very aggressive diets that people follow with long fasting, those patients need to be monitored more closely. Now, if they have abnormal kidney function, depending on the level of their kidney function, they will need to be screened more frequently.
I think, Dr. Hazim, from the amount of questions I can see, it seems that the topic
too much.
And perhaps it reflects that we in the MENA region, we have not been doing enough of the point or sessions on diabetic and the kidney.
Exactly.
And as the lead for the scientific webinars, I promise to try to organize another session to cover some of these topics, because it's an area that it looks like very popular from the number of attendees and the number of questions.
Exactly. Second and third, probably, not only second.
Yes. Yes, inshallah. We're delighted that we have Dr. Nizar with us today, first time to join the MENA sessions, and we look forward to him taking active role with us we always love nephrologists who with the high ability to take part in this voluntary activities for across the MENA region.
Thank you. I'll be happy to participate anytime.
Ala has been an active member in the sessions for several occasions. So inshallah, it will be fruitful for everyone.
Inshallah.
Thank you very much. You did very well. You did very, very well. Thank you very much.
Thank you very much.